Welcome to the Orthopedic Indications channel, where we discuss medical education for medical sales consultants and reps. This next case, a young female patient, it's all been females today, I guess, semi-professional MMA fighter, complaining of dorsal great toe pain. It's worse with activity at a fairly high level. Maybe not full professional, but semi-professional.
You better get this right, Nick.
Yeah, I know.
Yeah.
And so these are the x-rays. Lateral view, oblique, and AP view, only one side, unfortunately. But what do you guys think?
This is one where I might turn to an MRI and get a better sense of what lights up. You know that her cartilage is going to have some pretty significant wear, maybe more than that AP joint space would hint at, but that might help me have some good conversations with her.
Yeah, I think that's a great point. And trying to remember, actually, as I put this together, I didn't go back to see if we had done an MRI. Now that you mentioned, I think we did, but I don't have any of the images here.
Sesamoids look good. What's her range of motion?
Range of motion is good. Just pain kind of on extremes of motion, particularly with actually a little more plantar flexion. As you kind of maybe drape that EHL across the dorsum of the metatarsal. But mid-arc range of motion is not very painful. A little bit of grinding when you get into more dorsiflexion. It's, when you see her, it's not terribly swollen, but you can definitely palpate that knot across the top of the MP joint, and not interested in a fusion. Let's just say that.
No, yeah, I would not offer. This is
so. Let's say I'll play a scenario. I wish I had the MRI, but let's play the scenario that you see the MRI and there is some arthritic changes. How are you? And it's going to be mostly on the dorsum of the metatarsal head. What kind of things are you looking for the MRI, and how's that going to direct your treatment, or is that just going to direct the conversation you have with them?
Yeah, I think in this one, I'd love to hear what you think, Jan. Again, fusion's not on my mind for all the reasons that you guys are aware of. It makes me jump. This isn't your question, but I just can't help but spit it out. Is there a role for an Aiken or a Moberg or something maybe to complement your cheilectomy? Is her alignment drifting? Is there any role to kind of change the vector of her EHL by adding a little closing wedge phalangeal osteotomy? Is that going to have any bearing on the natural history of maybe her progression or her deformity? That comes to mind. I certainly don't have the answer to those rhetorical questions, but and then again, looking at the MRI to try to answer your question about any sesamoid change, trying to correlate that with any symptoms she might have plantarly. But I suspect that a lot of her metatarsal head is going to light up on that MRI, and to your point, I think that just helps me have transparent, open communication with her about realistic expectations. I don't think it changes my plan, though.
Yeah. Jan?
Yeah, I don't see a lot of these patients in my practice, but one of you've even interviewed like David Porter, on the AOFAS podcast. He deals with a lot of athletes in our here in Indy, and he'll do usually a combined osteotomy for this to take pressure off that area. And he'll even I've heard microfracture any OCD lesion within the metatarsal head. But he's fairly aggressive with the osteotomy and really when he gives talks to our residents and so forth, really says that many times just doing an isolated cheilectomy in some of these patients, you're not doing the full surgery for them, at least in his experience. So it's something that I would consider here, I think, for this patient. But yeah, advanced imaging otherwise, you want to see what's causing their pain, because I think it's going to be very hard to make them satisfied.
Yeah.
Can you go back to that lateral view, Nick? Do you have time?
Yes.
You know, I would throw this out to you guys and just ask, you know, what we hear this term, metatarsal elevatus, you know, maybe not on the orthopedic side of the camp, but, you know, that's a recognized term in pathology. I don't see any evidence of that here. I don't know if that's a concept you believe in or you're looking for. Jan, when you talk about osteotomy, maybe a oblique shortening osteotomy in the first metatarsal, is that part of it to kind of decompress or shorten? I don't have any experience with that,
Yeah.
but maybe on a more elevated first metatarsal, if you believe in that, maybe that starts to make sense. I'd be a little worried. She's almost a little cavus here, about you know, maybe plantar flexing that first metatarsal. I'd be worried about that.
That's a good point.
Yeah. I haven't had any experience with the metatarsal osteotomy. You know, and use the Aiken sparingly, or what Dr. Anderson calls the Mo Aiken,
Yeah.
sparingly. And just, you know, I guess from the perspective of, if I'm doing the cheilectomy, I want them, you know, on it pretty early and range of motion early. And am I going to hate to introduce a possibility of a non-union? You know, that's a little bit, it's not a great excuse, but I guess it's, you know, part of the reason I didn't offer that in this case. And looking back on it now, I think maybe that would be a reasonable option. I know that there was a relatively recent paper in FAI talking about distal metatarsal osteotomies for Hallux rigidus and showing some good results. So it has me a little bit interested, but I think if I was going to do an osteotomy, from my perspective, I'd do like the Mo Aiken osteotomy to correct a little bit of the valgus and get a little bit of dorsiflexion built into things. So these are the kind of the questions I ask. I like with osteotomy. Again, referencing you know, the very wise Dr. Coughlin, and you know, talking about Hallux rigidus. This is the grading scale. So if you're ever in the OR and you hear somebody say Coughlin and Schernus classification, I took this right off OrthoBullets, so you can. There you go, Jan. You can go
Thanks.
and find it off OrthoBullets, these different grades, but you kind of break it down somewhere between grade 2 and, you know, grade 2 or less, or grade 3 and 4 as a fusion. That's kind of how I think of it. I don't know if that's how you guys actually manage it or not, but that's kind of what I was taught and how I think through things. The cheilectomy, you know, traditional dorsal approach, similar to a fusion, and you know, taking off the osteophytes. And that picture there is almost universally what you see. You see that dorsal bone spurring, and you see the loss of articular cartilage kind of on that dorsal surface. And you know, at least in this article, Dr. Coughlin was fairly aggressive with taking a fairly aggressive cheilectomy, or doing a fairly aggressive cheilectomy to help decompress that toe. I actually used more of a minimally invasive technique. I did a cheilectomy with the MIS burr in this situation. And I borrowed some pictures from you know, Tyler and Kaplan on doing using the MIS burr, the Shannon burr, and then using an arthroscope. And let's see if I have pictures. I don't have pictures here. And using an arthroscope to put into the joint to kind of, basically from my perspective, just flush out all the debris, all the bony debris that's in there, document what the cartilage looks like, remove some loose bits and pieces of cartilage. And in these cases, I've actually been reasonably happy with how they've done using that technique. Jan or Tom, have you guys used any of the MIS burrs for cheilectomies in the past?
Yeah, I haven't. I mean, I've never done anything like this. I'm just kind of, I've seen some, you know, it's interesting. You just taught me when you said arthroscope. I've seen people scope these, or not seen them. I've seen photos online.
Yeah.
I don't know. I know it's maybe a little off, but have you, Tom, have you done with your MIS experience? Have you scoped these?
Yeah. So, you know, on this particular case, on the x-rays you showed, arthroscopy wouldn't come into my mind.
Right.
But I think on that topic, I've probably got 5 or 6 patients that I've done MTP arthroscopy on. So by no means a ton of experience there, but with a synovitic exam and a less osteophytic X-ray, no loose body, and an MRI that shows a central defect, I've had pretty good success with MTP arthroscopy in that isolated, indication, just cleaning up loose chondral flap and synovitic debris in a young athletic patient like this with less osteophytic change. That comes to mind for sure, particularly if your MRI kind of guides you there. And I just am not skilled enough, honestly, guys, to feel really great. These are great X-rays, and I know Tyler and John do great work with this. For me, I'm still kind of an open it up, maybe shrinking my incision a little bit, but still using a microsag saw. And really, it's always depressing, isn't it, to see how much articular loss you have there, and am I getting enough? And I'm maybe just not skilled and patient enough to kind of go through the burr and scope exercise for that.
Yeah.
I will say, I was, when I started this kind of journey where I've done this, it was I did the cheilectomies just with the burr, and then had a patient that just kind of got really inflamed from the bony debris that gets developed. So then thought, well, I'll use the scope and just to flush it. If nothing else, I'll put the scope in there and then just see what I can see. The nice thing about the burr is it kind of blows the whole thing up, and so you can actually get into the joint reasonably easy. It is a little bit of a hassle factor for sure, and there's times when it goes super smooth and it's 30 minutes or whatever, and it's no big deal. And there's times where you just can't see anything, and it's so hard to move around. So I don't know. I think it's a nice tool to use. Is it better than an open scope, or I'm sorry, an open cheilectomy? I don't really know, but it is kind of a nice thing to have in your toolbox.
Yeah, no, on that point, I've talked with Oliver Shipper a little bit, who, has a ton of MIS experience and really is, kind of a mentor for me personally. And I don't know what he's doing these days. I haven't talked with him about cheilectomy recently, but I know he kind of went back to open cheilectomy in personal conversation, and that made me feel a little better about myself.
Yeah. Yep. Well, we're running into an hour there. That I think is, 3 pretty good cases to kind of go through. I ended up using this in this case, and she, I don't have any post-op or intraoperative films, but did well with it.